is being recorded. Just had to do that. Thanks for reminding me. Last year, we invited the members from the Healthy Work Transition Listserv to join the new Youth Health Transition Listserv. So the Healthy Ready to Work people, we have that listserv. You've been added to the Youth Health Transition list. We have some new people joining us who maybe are not as familiar with who we are as some of you are as QI grantees. We would like to start by taking a few minutes to introduce each other. We would ask that you would give your name, your organization, and if you're a current shared plan of care QI grantee team. So we're going to start by doing this regionally. So we'll see if we can all do this together. So I'd like to start with anybody who is in. So again, my name is Tim Markle. I work with the Youth Health Transition Initiative, and I'm based out here in Madison. And so I'm wondering if there are people from the Milwaukee or the Southeast area on the call that could introduce themselves. And please feel free to unmute and then mute yourself again.
This is Betsy Roth-Wojcicki. I'm a nurse practitioner in pediatric rheumatology at the Medical College of Wisconsin and Children's Hospital of Wisconsin. And I have had grants the last several years on setting up and formalizing our transition program for teens and young adults with chronic rheumatic conditions.
Thank you. Fantastic. Who else from Milwaukee is around?
Oh, where's that?
Hi, this is Meg Steinley with the Southeast Regional Center for Children with Special Health Care Needs.
Tomorrow, the juniors have their test then
vocab?
on the vocab.
Okay.
So then that's
Please a reminder to mute if you are not.
And then I didn't make
Okay. Anybody else from Milwaukee area or Southeast?
I think Megan Teed was on.
I think so too. Megan, can you hear us or where'd she go?
Maybe she left.
Oh dear. Okay, well, let's go and see who is here from the Northeast.
I'm Chris Patras. I'm the nurse case manager for pediatrics at Ascension Medical Group in Stevens Point, and we do not have a grant.
Thank you.
Welcome.
Hi, I'm Jim Meyer, adolescent medicine at Marshfield Clinic in Marshfield, Wisconsin. We also don't have a grant.
Thank you. Anyone else in the Northeast area of the state? Oh, and thank you. Lynn did remind us in the chat function that some of us may not have microphones available or on the phone, so please feel free to use the chat to also introduce yourself. We'll also be using the chat feature to share the handouts if you did not receive them earlier this morning. And so, yes, Megan T did check in on the chat feature, and they are a new spot grantee. She is with the Children's Hospital of Wisconsin. So from the Northeast, let's move over to the northern part of our state. Anybody from the northern part of our state on the call today? And then moving over to the western part of our state.
I'm here. This is Dawn Stark, Western Regional Center.
Thank you, Dawn.
And Jordan checked in from Chippewa Falls Marshfield Clinic.
Okay, Melissa Jordan. And we have, looks like Allison Becks and Lauren Yonker are joining with Megan Teed from Complex Care Program at Children's Hospital of Wisconsin. So we'd like to welcome them.
Why don't we keep going?
Yep, just trying to keep updated.
Keep up with the chat, I know.
Because it also looks, I'm I'm not sure who it is, but I think it might be Jamie. No, it's not Jamie from Wapaka, but we have from La Crosse Schools, West Salem School District has also joined us. Lisa Andresen is also on the call from La Crosse. So how about from the southern region around the Madison area? Feel free if you have a microphone. If not, go ahead and put it into the chat box.
Hi, this is Colleen Lane. I'm with the Wisconsin Medical Home Initiative, and I have the privilege of working with the Shared Plan of Care grant teams.
And this is Sharon Fleischfresser. I'm with the Children and Youth with Special Healthcare Needs program, the Title V program, and we provide funding to support the Youth Health Transition Initiative.
This is Becky Burns. I'm also with the Children and Youth with Special Healthcare Needs program.
Anybody else who has not been able to speak into a microphone or let us know via the chat feature that you are here?
Yeah, I just saw Kristen Sodergren and her group from AFCH Complex Care Team. They have a transition-focused QI grant.
Yes.
And Cindy Griffith from the Children's Transition Work Group is on too.
Great.
Okay.
And I can introduce myself, Tim, when I start to talk. So do you want to, did you have any other opening remarks?
Just a few reminders till I get to the point where I will be loading things into the Zoom chat and turning it over to Ann. But during the call, remember that any background noise and conversations that are not muted on your line may be part of this archive presentation, and they may be distracting to other people. Control your own muting by using the mute feature located in the lower left-hand corner. For this call, we are definitely, though, looking for interaction, and we welcome questions, comments, and clarifications as we go through the slides. So please unmute yourself when you want to talk during the presentation. The presentation and accompanying materials will be available at a later date on the Health Transition website under the Learning Community tab. We hope you receive the agenda and handouts to help you participate. I will also be posting them in the chat feature where you will be able to download them. We will be providing a summary and opportunity for discussion around the assessment of healthcare transition activities. We plan to spend about 20 minutes to review and offer participants time to comment, reflect, ask follow-up questions, and then in part 2, we hope to have a discussion about how can you implement them, sharing your expertise around successful strategies for implementing transition activities. We will continue to monitor the chat box throughout the presentation, and if you would rather type your questions in the Zoom chat box, that is also fine. Any questions not addressed during the presentation will become part of the Q&A at the end. With that, I'm going to turn it over to Ann Harris to dive into the assessment of healthcare transition activities.
Great, thanks, Tim. And you'll probably have seen on the chat box and with Tim and myself that we have a team of 3 people, Lynn Robick, who's our evaluator, Tim Marco, who's our outreach specialist, and myself, who are the program lead for the Youth Health Transition Initiative. My name's Ann Harris. I'm at the Weisman Center, and as Sharon Fleischfresser said, we have the contract to do some statewide training and technical assistance around youth healthcare transition for practices and communities, and mainly for systems, although we are also happy to answer questions from families, but that's not our main purpose. We belong to the Children and Youth with Special Healthcare Needs Network, and there are other ways that you can refer families to our regional centers to have their specific questions answered. But our purpose of our call today is, and the objectives are, you should be able to see if you're on the Zoom on computer, are what Tim just reviewed. And I wanted to make sure that I sort of positioned this myself as more of a technical assistant on this call. I certainly understand and have reviewed and studied the rubric and the assessments for healthcare transition activities that we're going to be discussing. But it's the people on the call who are really experts in providing care to families in the transition process and really have been grappling with some of the issues. So we'll rely on you to share your experiences and your stories, and if anything I can do to just sort of help you reflect and use the tools that we're going to be talking about today, that's my role. So the first thing I wanted to mention, and it's still, I'm going to move to, I want to make sure we just understand what we're talking about when we're talking about the 6 core elements and our GOT transition partners. So I'm going to review a little bit about the background, and I know for some people it'll be review, but for others, you can start thinking about where you might want to make changes and or be working on this year, and we'll have some suggestions for that and discussion at the end. But there are, this slide really illustrates in a very brief form both the transition process and some of the ages associated with the transition from youth to adult care, as well as the 6 core elements, which are the 1, 2, 3, 4, 5, 6 at the bottom. And the rubric that we'll be discussing is takes these 6 steps and breaks them down into different levels of completion for each of the types of practices that is approaching or is a partner in the youth healthcare transition process. So just again, very brief review. These steps are somewhat sequential, but they can also occur in terms of the 6 core elements somewhat simultaneously. But we recommend that there's a transition policy in place for practices and for systems, that there's a method to track and monitor transition activities, that there's a transition readiness assessment or some kind of a process to figure out when families and youth are ready to make that planning process start. And then the actual planning process is step 4. The transfer or integration of the youth or young adult into adult care is the 5th step, and the completion and sort of confirmation of that transfer is the 6th step. So we'll be going through these in more detail, but the upper part of this diagram really helps to look at sort of age ranges and the family's role and the provider's role in trying to make the process smooth, if you can, for the youth themselves. So again, there's no one age that this process works best for, and it may depend on the ability and the independence of the youth that's undergoing the transition. I think the other thing that I really wanted to point out, and I'm going to back up a slide here, is to say that there are 3 types of transition that our GOT Transition National Initiative has outlined. One is transitioning youth to adult care providers, so if there's going to be a change in primary care provider. Another type of transition would be within a practice, like a family practice, transitioning from adult to, from a more pediatric-oriented care to adult-oriented care. So that's the approach change, where the primary care might not change, but the specialty care might change. And then there's the role of the adult provider in accepting or integrating those young adults. So what GOT Transition has done is developed these guidelines, and they've actually color-coded them for those 3 types of providers. So on the left with this yellow header is the transitioning youth to adult care providers. And we'll spend most of our time talking about this type of transition because that's what most of our practices are dealing with. But just to let you know that they have crosswalked across these 3 types of transition, what you can do in family medicine or med-peds providers where the primary care isn't changing, and then the role of the adult provider. And there's not a lot of difference between these, especially at the beginning, but on the second page of this crosswalk, when we're talking about steps 4, 5, and 6, there starts to be a little bit more difference in the roles and responsibilities of these different types of care. And the major difference that I've seen in the planning of this process is that if you're in step 4, you're actually identifying the adult providers that the youth is going to be going to, and then in steps 5 and 6 actually transferring the care. Whereas if you're staying with the primary care, you're more talking about how to start incorporating the youth and young adult in setting priorities and having the family step back if possible, and take a different type of role in the adult care, and then more referral to adult specialists. And then for the adult providers, obviously, the steps 4, 5, and 6 are quite different in terms of actually accepting them into the practice. So I just wanted to point out that those materials are available, and if you are partnering with others in your organization to accept young adults into their practices, then there's tools and supports for those folks as well, and how their role and participation in the process. But what we really was going to focus today on was the assessment that we've asked the QI grantees to complete every year, and just wanted to review some of how this tool can help you in the process of planning for that those activities that you'll be doing this year. And actually, I'm going to skip ahead a little bit, and excuse my fast forwarding. We'll go back. But using this self-assessment, which is a rubric and allows you to rate yourself on the 6 core elements as well as 2 around family and youth engagement, is really helpful in getting your team members familiar with those steps in the transition process, and potentially identifying what areas of focus for change based on your current state could be where you want to work. And then it can also be useful for tracking process and progress. So what I'm going to do now is to share with you one assessment from last year's QI grants, just to show you the range of responses that even a group that was very focused on youth health transition, a group of practices, had. And so these were their initial assessments, the baseline assessments, and this graph shows you the rubric of 1, 2, 3, 4. So a 1 being that you haven't started on this, and a 4 being that you feel you're doing pretty well on this. But the range of the scores is actually quite large. So and this was baseline. So this is not progress. This is just where people started. So just pointing out that most practices are somewhere in the middle of things happening if you've been thinking about transition, and many people start at the very beginning. So I'm going to go back and we'll walk through those elements. So that's the first page of the assessment, and again, if you can't see it on the screen, I'm hoping you can pull it up as a handout. So we're going to start with the second page, which has the transition elements of 1 through 4. And again, the title is pretty self-explanatory. I know you probably can't read it on the screen, but I do. I'm just going to point out some of the key features of each of these elements and how they're asking people to rate. And also that in this rating system, to be useful, one of the things is to really think about what level you've completed. And we ask people and it says that on the first page of the document, to really think about completion. And if you're partway through the next one, score yourself at the lower level, and then you might want to work on the next, how to complete the next step. So for transition policy, this is basically saying that there isn't much of a policy, that clinicians vary in their approach to healthcare, and there's not a clear or written policy. Level 2 says they might follow a uniform but not written policy for the age of transfer. Level 3 says the practice has a written policy, but it's not necessarily consistently shared with families. And the 4th level is that the policy is written, it's in place, everybody's using it, and families are getting this information, and it's even publicly posted that these discussions start between ages 12 and 14. So again, the rubric goes from basically not happening to pretty fully implemented. For transition tracking and monitoring, they're talking about how you're identifying youth that are ready to start this transition process, and then documenting the process that they're going to go through. So this is where using the electronic medical record comes in, and how and again, people are just identified to go through the process. So again, the key features are that there's some kind of a tracking method to, it could be a flow sheet or something in the electronic medical record where people are identified, and no later than age 14 to be going through the transition process, and then that the practice in level 4 has the tracking system firmly in place and is using it. Transition readiness has most to do with the communication with the families and about what's the process, and it starts with variable communication and seldom. The second element here, and some of these indications have 2 elements, and some are more tracking 1 element. But this one actually has 2. So one is having time alone, and the other is the transition readiness assessment. So for that, it starts with not doing that consistently, and it's moves into clinicians consistently offering time alone for patients or youth over age 14. And again, this has going to vary based on the medical complexity and the different elements of care for the specialty care clinics in particular. And then moving into implementing a standard practice around offering time alone and assessing readiness skills. So this is definitely part of interaction with families, not something that the clinic can do on its own. For transition planning, this is where the overlap between the shared plan of care really starts to come in. So this element discusses having a plan of care, and in level 1, it's seldom making that plan of care available, all the way through having transition goals and an updated shared plan of care that's regularly used. The last thing that they mention in level 4 here is actually they add in something around making decisions, that decision-making supports have been discussed prior to age 18. Is there anybody who wants to ask questions or clarify any of those elements as we sort of move through this fairly quickly and then allow for more discussion? Okay, I'll just review these last 4 are on the rubric. The last 2 steps of the 6 elements is on this, as well as the youth and family engagement. And I did have some discussion prior to this call with some of our grantees and colleagues that said they would like more discussion around the youth and family feedback and leadership. So we'll be able to do that as well. They're not part of the 6 core elements, but they are included on this scoring rubric. So the transfer of care is really self-explanatory, but it basically, the elements that they're looking for are sending medical records and communicating about those transfers. So level 1 would be that you might send medical records, but in response to a request, but you're not proactive. Level 2 is more consistently being proactive in sending those medical records. Level 3 talks about a transfer package that includes the shared plan of care. So again, there's overlap with the shared plan of care goals. And then level 4 is that the transfer package has been sent, is being used, and the clinicians are communicating directly with the adult clinicians. The pediatric, sorry, are communicating with the adult clinicians, confirming that everybody's clear about the responsibilities during the transfer. And then the final is really more of a follow-up and confirmation of completion of transfer. And that has to do with not having a process to do that, all the way through confirming the transfer completion and getting feedback from the patients regarding that experience. Which leads very nicely into the last 2 elements of this rubric, which are the youth and family feedback and the youth and family leadership, which also are really nicely aligned with our current grantee initiatives to really engage with families and youth throughout the process. But the rubric has divided these 2 divided it into two elements. One is more focused on potentially an easier step, which is basically getting feedback from youth and families about transition processes, maybe surveying families, and then involving them in reviewing and helping develop the survey. So it's more, and any other materials that might being used for transition planning, readiness, and implementation. So that is more engaging around the process and getting feedback from families. The second, or the leadership element, is more focused on having families participate and youth participate in the process really conceptually during planning and then implementation, maybe as part of an advisory council or as part of your grantee team, or really all the way through the helping the practice develop and implement their transition process. So the rubric does have a 4-point scale, and there's a 32-point scale, but we aren't really concerned with the score here, although if you like to score things, you can certainly use this as a scoring, but we're more concerned with using this as a way to help focus your efforts, help clearly define potential steps and actions that you can take, and also to track progress over time. So I was going to share another, briefly, another set of data that our evaluator, Lynn, put together for us. And this is from 2 years ago, because we're still putting together our data before, our pre and post data for 2018. But this slide shows in the light blue where a Clinic A started and where they finished in their pre and post assessment. So for transition policy, the first element, they said they started at a 2 when at the beginning of the year, and they were at a 4 at the end of the year through developing their process, through their QI processes. So again, there's not required that you make a change in every area, and some clinics reported no change. So for element 2, Clinic C had no pre-post change, or Clinic D didn't try to make changes in element 5. Or sorry, 3 here on the readiness. They were already doing it to some extent, and they continue to do it. So those are just one way we use it to track, and why it's important that you really think about this ahead of time and focus on a certain area. This last data slide shows that for the family, feedback and engagement with leadership is an area that a lot of our grantees in 2017 felt that they needed to work on, and had they were starting pretty much from a 1 or a basic 1, and then had made some steps. So again, not everybody makes steps in all areas. That's not what we're talking about here. We're saying we just need to know what would be helpful as a place to start, and where this kind of a specific rubric can help you decide what you want to work on. So I pointed out in talking through the rubric the 3 elements that specifically relate to the shared plan of care, and elements 4 and 5, it specifically mentions having a plan of care as part of the transition process. And then in element number 3, there's transition readiness checklist. That's where you rate what you're doing with that. And that's another tool that we're encouraging our grantees to use. Many clinics actually use that even without some of the other elements. So that's something that you might choose to incorporate into part of the shared plan of care work, and as well, or on its own. I would like to come back to this and talk a little bit more about youth and family engagement, but I didn't want to, I just wanted to point out that for many years, when we were working on our transition QI grants, we really said, if you're just starting out, make sure that you've talked about transition that you've got some kind of a written plan, and that you're, and this kind of goes up in your system to who else is supporting implementation of that transition policy within your system, and are other clinics working on it, and do they have already a written policy that you can adapt to your clinic, or is there maybe a policy or a guideline coming from the entire organization that clinics are being asked to implement? So again, I'm not, that's all I had to share today, but I also wanted to hear what your questions might be, and then talk a little bit more about what we might want to work on together, and where you might want some more help, and we can figure out how to get you that help. So actually, I'll just leave that one up and then open it up a little bit for discussion. I know, and I can go back to any of the other slides if people want to talk about specific points. So I know a few of you have just completed your pre-assessments. Was there anything that struck you as you went through those? Oh, that was just looking to see, because I don't think Megan has her has a microphone, but I know a couple of people who hadn't done it before.
This is Betsy.
Okay.
From Milwaukee at Children's and the Medical College in the pediatric rheumatology area.
Mm-hmm.
I think what has been helpful for our subspecialty is that the institution as a whole has taken this on as a priority and initiative. Mm-hmm. What I have done and our group has done is a couple things to, a couple of years ago when we got our first grant, developed a formal transition policy for our subspecialty. And we had everybody on the team, which included all of the physicians, myself, our social worker, our psychologist, and the staff nurses to agree on the policy. We had a parent and a teen who also worked with us in identifying what we felt was appropriate before it was all signed off. And so that everybody knows what we are trying to accomplish. And what we have done in our subspecialty is on a formal basis, started to formally talk about this at the age of 15, realizing that our institution is doing it at 12, and it's not that we don't do it at 12, but with some of the drugs that we're talking about in the disease process, we've already been educating about that, but really at this age, start really feeling that they need to start taking ownership of this. At a younger age, they listen and they know a little bit, but they really are not ready yet. Mm-hmm. And I think that that has been helpful. I think the other thing that we did ourselves, a little transition checklist in the beginning, just so asking them, do you know what your diagnosis is? Do you know the names of your medications? Do you know why you take them? Do you know how often you take them? And we use that, the transition checklist that's now within the 6 core elements and that's available for people is much more specific. And last year, I was using that, and it was very helpful when we're into the process a little bit more to see what you've already accomplished and bring up new topics. Mm-hmm. We have at our institution in EPIC a transition checklist that the institution is using in various different subspecialty areas. And so you can kind of check off what you've gone over and then reinforce that. And I think that that's helpful. So, you know, you can give the checklist once a year, once every 6 months, and say, okay, now you feel comfortable about this. Why don't we talk about, as you're going closer, what insurance means? What do you need to know about insurance going forward? What do you need to know about copays and all of those different types of things that obviously is more at a later age than at 15 or 16. So we've had success in those areas.
Yeah, thank you. Thank you, Betsy, for sharing. Anybody else have a policy that's, I think the AFCH has what they call a set of guidelines. So I know that the AFCH clinics have been adapting and using those, but it sounds like you actually did a kind of wrote something very specific for your clinic as well. And I guess I was thinking about our complex care teams as well, that I'm not sure if that's happened, that you've taken that general policy and tried to adapt it or look at it for the complex care teams. Sharon?
I was going to say, and there's some information from the complex care programs in the chat.
Oh, great.
So,
yeah, I can stop sharing my screen, but I'm wondering if you're seeing me look at the chat when I look at it.
No, we don't.
Yeah. Okay, good, because I just wasn't sure what
well, the chat is available. It looks.
Yep.
I
can see it.
Okay, great.
Yeah. Yeah, I know about the guideline, but not a formal policy, and that's where I'm thinking that we may need to potentially, think about how to adapt that general guideline to a very complex care population. And then from Megan in the at CHW's complex care group, she says it's extremely hard to adapt as they can see 14 to 16 specialists. So I think at the point of, you may want to have to narrow down what part of the care is going to be transferred and when. And so I think that is something that actually I have talked to several people about and seen in some examples, is that you might start with, what's available in an adult care setting. And a lot of times some of the pediatric specialties might continue until an appropriate provider is identified that can cover that area. I don't want to necessarily promote this, but unfortunately what I have heard is that some, with multiple specialties, some do transfer into adult care and some just don't have an adult counterpart, and then it stays with maybe a more pediatric focused. But that's just part of what's available. Anyone else have thoughts about either the policy, or I was also struck by the age, so maybe there's like a general guideline around the age of things to start, but again, with special populations, you might need to adapt that.
This is Tim, and I'm thinking that this is one of those areas that I think ties really well into the shared plan of care work, because as we are talking about who is doing what in the shared plan of care and who's responsible for it as we deal with transition, is that may be a really good place so that everybody on the team, including the parents, understands when that subspecialty, that specialist is going to get transitioned. How long are they staying with that specialist? When should they stop calling that specialist? Who's going to find the new adult provider? Is it in the hands of specialists, or are the families expected to do that? And so working those out through initiating a shared plan of care is a place where everybody, including the families, can get an idea of the complexity, but also then see who has the responsibility to reach out so that it can be followed up on. Not in the sense of who did or didn't do it, but, oh, this needs to get done. So I think that integrates really well with the shared plan of care.
Mm-hmm. Is there anybody else who has some something to share that has worked in either that relates to any of these elements, and we can move into more of a focus on engaging with the families and the youth, which is a question that I had received. But I'm really thinking just, is there somebody who's done a piece of this? Because that's really what this rubric does, is breaks it the process down into the different elements as well as sort of the different levels of implementation. But anybody has anything that was successful in moving from one level to another or moving from one element to another? Some of the things that I'd heard from people was, again, both challenges as well as some successes, and with working with families and getting families and youth more engaged. So maybe we could move into talking a little bit more about that. And I do know that there, people on this call that are some maybe more generalists as well as specialty providers, but are there specific questions that anybody has about how to even start those conversations or identify youth who might be interested in participating? Is this Tim that just shared the youth engagement toolkit on the chat box?
Yeah, I find this to be a really nice, simple tool that lays out it goes through a little bit about why do you want to have youth engaged and gives some pretty good ideas about how to, base the engagement. But of course, the challenge is going to be, especially as we deal with the complex care program, how is this adaptable to the population? And that's probably going to take a longer discussion than we have today with the teams. But I think it's an important discussion to have because, we really do want to be about empowering the adolescent to become empowered adults.
Well, one of the things that the rubric helped me to think about was we have a number of different tools that we use around family engagement, but with this idea of on the rubric of the two levels of, I'll go back to that slide. And I know it's small, but this idea of getting feedback and then leadership. So I thought for the more complex individuals, there would certainly be ways to get feedback on approaches, like depending on the communication ability of different youth in the practice, there might be ways to find out, starting with some fairly simple kinds of things like how do they like to be introduced, and who do they want to go with them for visits, and more directly related to if you were going to meet a new provider or have a time with a provider on your own, how would you what would you do with that time? So I know it's a little different, but I still think it's important to think about those considerations even with people with different modes of communication and abilities to make decisions.
And going back to to Tim's comment about the shared plan of care, those could be elements that could be included in that shared plan of care as well. So other partners in supporting this family and youth would know that information as well.
Mm-hmm.
And just want to point out that Megan from Children's has just come into this. In the chat, it said that a huge challenge in getting family patient buy-in to transition at the complex care program in Milwaukee is that they're usually the first person, the first medical personnel there to be addressing transition. And since they've not found an equivalent complex care in the adult world, the MedPeds providers are great, but most aren't accepting new patients right now. Our hope is that by starting these conversations at 12, that we will have more youth family engagement.
Yeah, and certainly starting those conversations earlier, and I'm always trying to keep the youth perspective in mind, but really the families are the ones that are going to be supporting that course all the way through. And if it's the first time they've heard about transition, sometimes they're still just getting used to, at age 12, they're sort of halfway through that, if you will, childhood spectrum, and they're kind of, I often hear from families that they're kind of surprised that they have to think about transition as early as that. But it is true, and similar to one of our clinics here who starts to talk about college at age 2. It may seem early or premature, but in actuality, mentioning it as early as possible and coming back to it, saying, obviously we're still working on getting your pediatric needs met, but this is a shorter term care structure than, and again, not all conditions have long survival trajectories, but they will eventually move to adult care, and will need to have the emergency plan, and that's where the shared plan of care comes in, and be able to communicate with a new set of providers and have a lot of those things in place. And so sometimes my point is that the parents need to hear that as much as the youth, especially at these early ages. So it may be more like family engagement at those younger ages that we might be thinking about measuring here and working on, and then having the families and obviously bringing their youth along with them, figuring out how they can be more, how you can get more feedback, or how they can be more involved in planning that process for other youth that are to come after them.
This is Sharon again, and I think that I know that for example, the cystic fibrosis program, and I can remember this, hearing this from Craig Becker, the social worker, saying that really transition, and I think you've said it as well, and that it really begins at the time of the diagnosis, only it's setting the stage. There's certain events that happen at certain age, and sometimes they don't. I mean, to Megan's, I think it was Megan's point about, cardiology may stop seeing patients, another specialty may, just the whole kind of complexity of that. But it's, being able to start that discussion early so that it's really a process that takes time. Not to put other folks on the spot, but I know we have some folks on the that are participating that don't have grants and may not be from complex care programs, or may see adolescents who are generally healthy. And so just curious from those participants, thoughts about transition processes within their own clinics. And I may have muted myself before I finished my sentence. Just curious to see how others might be approaching this as well, even for kids without complex care or without special needs. Note takers to share kind of how they're approaching it? All right.
Hi, this is Beth Van Langenberg. I'm not primary care. I'm actually ped diabetes at AFCH. While our institution has a guideline that starts at age 12, and the diabetes team, we actually start at age 8 and earlier if it seems appropriate. Finding that the disease itself is so complex, I'm not anything like complex care, but lots of things for kids and families to know. So the earlier we start talking about even very simple things like whose responsibility is it to test your blood sugar, and what are you doing to participate, we can start that much earlier than 12 or 15 or 18. So we've had some success with that. The other thing I was thinking about in terms of the youth and family feedback and the leadership, one thing that we've had some success in doing is starting a transition clinic. So we have a pediatric provider and an adult team provider who meet with young adults sometime between the age of 18 and 20 and talk about like the differences between the pediatric practice and the adult practice, what that young adult can expect when they get to the adult team. And it's very conversational. There's no, we don't pour over blood sugars or talk about, particular plans of care, but we talk about, that what that difference will look like for them. So I think in a roundabout way, not nearly as direct as this flow sheet would show, but in a roundabout way, we talk with the family and the young adult and get their point of view. By the end of that transition clinic visit, usually the adult provider, it's one of the adult CDEs, will think about who this individual is and who they think will be the best fit for that person when they get to the adult clinic. And so that's kind of nice. And then the young adult has a name and a face, someone they've already met. They've learned that the adult clinic is not scary, and that the people there are there to support them and offer them encouragement. And we've had really good reviews from families about it. When young adults attend the transition clinic, they are not committed to a transfer of care at that point. They can go back and see the providers in the pediatric clinic if they so choose, or they can, take that next step and transfer all of their care and move on to the adult clinic. It's really up to the young adult.
Great, thank you, Beth, for sharing. That's really helpful. I mean, we have had quite a bit of debate, and when there is a significant enough population, I think that makes total sense. Transition clinics can be very successful, and again, you kind of need a critical mass to be able to do something like that, and obviously some adult providers to take on, and there are in diabetes, I know. But our debate is, to do a transition clinic or not. But I really liked what you just said about that they aren't committed necessarily, just by having an appointment in the transition clinic. But that just sounds like a really supportive way to ease the transition. Because I know I have heard from families and providers both that, if sort of that transition happens really abruptly, like in an ER situation or the next hospital admission, there's, it can be kind of a shock. And that what we're trying to do is plan for and avoid those kind of abrupt and unsuccessful experiences. So that's really nice that they have that flexibility, knowing that eventually they will have to transfer, but just how and when that happens is more under their control.
We have had trouble with attendance at the clinics, and volume is an issue because, as you pointed out. So we've played this year with changing the timing of our transition clinics. We offered 2 in January when students are home on winter break. And then we have, I'm not sure if it's 3 or 4 clinics scheduled over the course of the summer, and probably one again mid-fall. So we're trying to accommodate when college students are home from school, high school students, although there aren't very many high schoolers that attend the transition clinic, but if they so chose that they could do it when they're not in school. So that is an issue we keep trying to adjust.
Yeah, and that sounds really helpful to know about that. I mean, it's true that I think by the time they get to college, they're realizing that they're in the middle of the transition no matter what. But still, timing it in a way that you can hopefully line up with when they might be available, and thinking about it is a good strategy.
This is Meg. If I can just interject this really quickly, I know we're running low on time, but I know that Terry Cohenhoven with the Down Syndrome Clinic here at Children's is going to be developing and piloting, hopefully, a transition clinic within their clinic. So if I learn anything, or if I can encourage Terry to get on a call, I don't know what her hours are, that she could share that information, or I can share it on her behalf.
That'd be great. And actually, we're thinking about something like that at here at Wasteman Center as well. So I know that'd be great if we could have a discussion about sort of how to do a transition clinic within a clinic. I think other people might be interested in that. Are there any other topics that, I'm open to more success stories. We've got maybe a minute or two here, but and I think Tim maybe have some wrap up. We'll send out a link for feedback, but and you can, on the feedback link, give us new topics. But does anybody have other sort of burning questions that we should be addressing in the future for one of these learning community calls? It's hard to think right off the top of your head. Maybe transition clinics in general, both standalone and within a practice, and sort of, I know there's questions about, do you do a warm handoff? Do you do a, what in the adult rubric, the adult practice rubric, there's some really nice guidelines on how to accept patients and how to integrate patients. So one of the emphases that we're pushing for in the next, we've always been eager to do this, but we're really looking for more adult providers to engage with us in this work, and to work with them on, how to really make their end of the transfer process a little more, I guess I'd say systematic, as well as predictable, maybe, for people. So we'll be more to come on that one as well. Tim, did you have, I think we are on our last couple minutes, so did you have I can stop sharing, but.
So I have posted the link for the evaluation in the chat box. We'll also be sending that out to participants afterwards to make sure that you have the opportunity to let us know how it went today, but also, more importantly, things that you want to share with us for the future calls, and what sort of things you would like to cover. With that being said, our next Youth Health Transition Learning Community Call will be Thursday, May 16th. And as some of you may know, the state of Wisconsin recently passed a new supported decision-making law. And so we will be talking about how the supported decision-making process can work, where this new element, this new tool, can fit into the supported decision-making process, how to engage families around supported decision-making. So that'll all be, we'll be looking forward to that on Thursday, May 16th. More details coming out a little bit later.
Great. So thank you, everybody. And any final comments can go in the chat box, or we'd really appreciate your feedback on the form.
Thank you, and have a great afternoon, everyone. And thank you, Gemma. I see your note, and I shall have that done.
Thank you.
Thank you.
Okay, bye-bye.
Thanks, bye.